Welcome back to the San Antonio Breast Cancer Symposium, and this is webcast number 6. I'm joined today by Julie Doughty, a surgeon from the Western Infirmary in Glasgow, and I'm Susie Cleator, breast oncologist from Imperial. And we're going to discuss 2 presentations from this morning that deal with local aspects of breast invasive disease and DCIS, respectively. So the first of these is a randomised trial looking at partial breast radiotherapy delivered by accelerated IMRT radiotherapy versus standard whole breast radiotherapy, and this is looking at the 5-year survival results. And this was presented by an Italian group. So there's been a lot of interest for a while in partial breast as opposed to whole breast radiotherapy. We know that most local recurrences occur in the index quadrant, and it's an attractive proposition to deliver partial as opposed to whole breast radiotherapy because it is potentially associated with less toxicity because we're using a smaller treatment volume, but it's also assumed that we can only accelerate our treatment if we give partial breast radiotherapy. In fact, that's probably not correct because in the UK we do actually have a trial currently going on of accelerated radiotherapy for whole breast radiotherapy. But in any case, and the radiotherapy here was delivered not by standard tangential technique in the accelerated arm, but by much more conformal IMRT. And although it's more conformal, though, it's important to note that with IMRT, more of the neighbouring breast tissues, and in particular the contralateral breast, deliver a small dose of radiotherapy. So the primary endpoint was ipsilateral breast cancer recurrence, and the secondary endpoints were overall survival and treatment toxicity. So in the partial breast accelerated IMRT arm, the dose was 30 gray in 5 fractions over 2 weeks. Now, there was no discussion over how that dose was reached. Probably, unless treatment times are very protracted, the overall treatment time does not matter that much. So probably they could have got away with giving 30 gray in 5 fractions over a week, which is similar to the dose being used in the UK Fast Forward study, but slightly higher, and I would suggest possibly unnecessarily high, but time will tell. The standard arm was acceptable. It's an international gold standard, 50 gray in 25 fractions as the whole breast dose, with a boost of 10 gray in 5 fractions. I would point out, however, that in the UK, following the START study, we've gone over to a slightly lower whole breast dose, a 40 gray in 15 fractions, which is given more quickly over 3 weeks. And we're very selective in the UK about who we give a boost to. We know that it causes more breast fibrosis and that it's probably not necessary in a lot of cases. So this was for patients who'd had breast conservation, and they were generally low-risk patients, smaller cancers. They had all had quite wide margins of excision, 5 millimeters, and over 40 years in age. The median follow-up was 5 years, and it's a relatively small trial, 260 patients in each arm. And this is the demographics, just to impress upon you that most of the patients were T1, and there were relatively few node-positive patients. So there was a very low, this is the results now, there was a very low event rate. The ipsilateral breast recurrence was just 6 overall, so 3 cases in each arm. And overall, the cosmetic result was deemed excellent in 90% of cases. So in terms of the primary endpoint, no difference in ipsilateral breast cancer recurrence, just 1.4% versus 1.5%, so very low in both arms. It's so few events that you wouldn't really have picked up a difference anyway unless it was extraordinarily marked, and not surprisingly, no difference in overall survival. Coming to the safety data, less acute skin toxicity in the accelerated arm, not surprisingly, because it's a lower dose. But even then, the grade 3 skin toxicity was low in the whole breast irradiation arm, 7%. Early, late side effects, it's really too early to talk about these. There were none seen in the accelerated arm, and there were just 2 cases of grade 2 fibrosis in the whole breast irradiation arm, which I would say is very small for that dose with a boost, but longer follow-up needed. And overall, excellent cosmesis in both arms. So this is certainly the first randomised study looking exclusively at accelerated partial breast irradiation delivered by IMRT. There was no statistically significant difference in ipsilateral breast recurrence between the two arms at 5 years. I'm not surprised the event rate was very low. Slightly, the accelerated partial breast irradiation, not surprisingly, slightly better tolerated with respect to acute toxicity, skin toxicity, which we know is not a huge problem anyway, and really too early to talk about later toxicity.
So Susie, can I just ask you, at the end of the presentation, the discussions, the presenter was asked, did he think this was going to change practice in Italy? Do you think these results are practice changing or will change anything that we do?
Well, there were two different things from the norm that were done in the test arm. One was to apply IMRT and one was to use probably a very slightly hotter dose than we use now, but given in a smaller number of fractions and given quicker. Well, I don't think we're suddenly going to start using IMRT. So IMRT means beams coming in from multiple angles, not just your standard tangential beams. And to be honest, you don't need to do that in most cases, even with whole breast radiotherapy, even less so with partial breast radiotherapy. You can get your dose in with standard tangents, treating very little in the way of normal tissue outside of the breast area. The second question of partial breast radiotherapy, I don't think this informs us really. The event rate is too low, and we're going to have to wait for bigger trials like Import High, and whether we can give a kind of standard dose in a more accelerated fashion. Well, I think in the UK we'd be interested in giving the dose quicker than this, possibly over a week, and the Fast Forward study will inform us about this. So I don't think practice is going to change in the UK as a result of this trial.
And one of the Americans thought it was a negative trial because it was equivalent, and she made the point that certainly in America giving this type of radiotherapy is much more expensive. Is that the case in the UK? Would it cost more to deliver IMRT than whole breast radiotherapy?
Yes, it would. I mean, we're not funded for it in the tariffs. I think it's important to realise that when radiation oncologists in the UK talk about IMRT for the breast, there are two different forms of IMRT. There is simple IMRT, which we do routinely, which is still tangential based, but kind of several smaller fields within those tangent fields, and we get a standard tariff for that, and it's not much more complex than what we do, and it's fine tuning, and the dose homogeneity that we get is very good in most cases. Complex IMRT is much more expensive, we don't get funded for it, and its use should be restricted to cases such as very medial breast cancers, people with pigeon chests, for whom standard tangential radiotherapy does not give good and safe dose distribution.
And I know that this was a trial started quite a long time ago, but from a kind of surgical perspective, I would be concerned of a trial where the margin acceptance was greater than 5 millimetres, because that in itself, I think, is going to impact on cosmesis.
Yeah, I don't think that reflects current practice. As you say, yes, we would accept smaller margins than that. We think it's safe and the cosmesis is much better. Yeah. So we're going to move on to the next presentation presented by Julie.
Okay, so the next presentation in this session, I think, is a very interesting presentation. It's looking at, it was a large prospectively designed study looking at the DCIS score predicting recurrence in patients after wide excision only who had ductal carcinoma and situ. And this was presented by the Canadian group. And I think it's important because at the minute in the UK, we are concerned in the screening programme about potentially over-treating patients. There was a big review recently which showed that we are over-treating some patients, and I think the difficulty always is identifying the patients in whom If we do no treatment or less treatment, they will not come to harm. And so we're looking at ways of picking out these patients, and I think this study has looked at doing this. We all know that ductal carcinoma in situ is associated with good survival rates, but some patients do recur, and unfortunately when they recur, they don't only recur with ductal carcinoma in situ, but at least half of them will recur with invasive breast cancer. Breast conservation alone without radiotherapy or without tamoxifen is an option, and it's trying to pick out those patients and whom we can safely do breast conservation alone. And biomarkers are needed to try and improve this risk assessment, and this is really what this paper has looked at. So we are aware of Oncotype DX used in patients with ER-positive, node-negative breast cancer, looking as a recurrence score, and also looking and identifying the patients who will benefit from chemotherapy. And this group are looking at Oncotype in ductal carcinoma in situ, and it's exactly the same. It's a multi-gene assay, and similar to we do in breast cancer, they have divided the patients as a continuum DCIS score from 0 to 100. Low risk is different to how we classify low risk for breast cancer. It's patients with a score of under 30, intermediate, under 39, intermediate 39 to 54, and high risk greater than 55. So this study is looking at it's a population-based study, and it was an actual huge amount of work, because what they did was they looked at 130,000 pathology specimens, identified patients who had DCIS, then looked at the cancer registry for recurrence data, so it was a huge amount of work. And the primary endpoint was to see if the DCIS score using Oncotype is associated with the risk of local recurrence, and that could either be ductal carcinoma in situ or invasive cancer in a group of DCIS patients treated with breast conservation surgery alone. All of these patients had negative margins, and the presenter was asked what defined a negative margin, and basically they would accept no tumour on an inked margin, which is similar to what the American guidelines are today. Initially, they were just going to look at ER-positive patients, but as the study went on, they decided to look at all patients regardless of their estrogen receptor status. The secondary endpoint was to see if the DCIS score is independently associated with local recurrence, adjusting this for significant clinical and pathological factors, and to see if the DCIS score is associated with the risk of invasive local recurrence and DCIS recurrence. So as I've said, this was a population-based study. They looked at all the pathology reports in the province of Ontario in Canada from 1994 to 2003, and they were specifically looking at the patients who had had breast conservation surgery alone and negative margins. So out of this 130,000 pathology reports, they actually identified 1,658 who had had breast conservation surgery alone. Of those, they could only obtain the tissue blocks from 828, and out of those 828, they had to exclude 257 for a variety of reasons, most commonly that when they did have the blocks, there wasn't actually enough material for the assay to be performed. So the study cohort, out of that initial large number of potential patients they could look through, was 571 patients with ductal carcinoma in situ who had negative margins and who had breast surgery alone. There was quite a long follow-up. It was 9.5 years. They defined local recurrence as either DCIS or invasive breast cancer in the same breast 6 months after diagnosis. And in this group, 100 patients developed local recurrence, and as we would expect, half of those were invasive recurrence and half were ductal carcinoma and situ alone. And this gave a 10-year risk of recurrence of local recurrence of 19.2%. Now, if we look and break it down into the 3 groups according to Oncotype DX, so the low group in the blue, the intermediate group in the red, and the high-risk group in the green, you can see that using Oncotype does differentiate your risk of recurrence. So if you have a low risk, then at 10 years, your risk of local recurrence is 12.7%, and this goes up to 33% risk of recurrence at 10 years if Oncotype assesses you as being in the high risk group. So using this DCIS score as a predictor of local recurrence was found to be significant. So the conclusion from this study is that the DCIS score is associated with the risk of local recurrence, both invasive and DCIS, in a population-based study looking at DCIS treated by breast conservation surgery alone. And this DCIS score allows us to improve risk stratification. It may help us improve the decision-making and possibly will help us decide which patients we would safely do breast conservation surgery alone. This is only the first analysis presented by this group. They are now looking at patients with DCIS treated with breast conservation surgery and radiation and seeing if using this Oncotype score can stratify patients in a similar way, and that will be presented at a later date.
So thank you, Julie. So, I mean, it's long been something that we've been aspiring to do, to identify those patients who have a low risk of local recurrence with wide local excision alone. Now, there are various indices, scoring systems that we could use. Now, they didn't compare this with, for example, the Van Noy's, which is the most commonly used one.
I mean, they didn't, and the presenter was asked that, and she said, no, we didn't. And I think the reason for that is that they were unable to find out the size of the initial DCIS, and obviously size is an important part of the Van Noy's prognostic index. And so they didn't have that in about, I think it was 40% of the patients. So they couldn't do it. And again, I think that's really important because clearly Oncotype was an expensive test. And I think you would need to know, is that better than the kind of clinical prognostic tools we have out there?
And I mean, how good was this test at identifying the low-risk patients? Do you think, I'm going to get the curves up in front of us, do you think that is low enough for us to withhold further treatment? So 12.7% at 10 years, and normally we'd say about 50% of recurrences are invasive, 50% pre-invasive. In fact, in this study, more than half were invasive.
Well, I think if you look at those curves, they appear to be continuing to go up. So although, you know, these are the risks of recurrence at 10 years, with longer follow-up, it may become higher. And I don't know if you said to a patient, if, you know, you've got ductal carcinoma in situ, if we use this test and you have a wide excision alone, you have a 1 in 10 chance of getting a recurrence at 10 years. And, you know, you've then got a 50% chance of that being invasive cancer. I think most people would opt for other treatment. It will be interesting, however, to see whether if you give radiotherapy, if that alters the recurrence rates, or if you still stratify them into 3 groups. But to me, that seems quite high.
So, I mean, this doesn't predict for benefit from radiotherapy, does it?
No.
I mean, for example, I mean, it's interesting, you don't really need to split the high and the intermediate group. They're pretty similar. And in fact, the intermediate group ended up being higher risk than the high risk group. But, obviously you're going to want to offer radiotherapy to patients who are at a 1 in 3 risk at 10 years. But probably you're going to modify the risk in some, but not all. But we'll just have to wait for analysis.
Looking at that, I'm not sure if this test identifies a group with a risk low enough that you would be happy to omit other treatment. That would be how I don't know whether you agree with that, but it looks to me, I don't think a lot of patients would necessarily buy that with that risk of recurrence.
Well, and the other thing is that it's a shame they don't have the size here. With a lot of these molecular profiling tests, we're finding that when you add in the clinical data, the size of the tumour, for example, you improve the predictive power, the discriminatory power. So it may be that you can combine this Oncotype test with the features that you get in Van Noy's and end up with something more meaningful. I wanted to ask you just one other question. So what do you think the UK practices with margins for DCIS? Do you think it's the same as invasive disease? Do you think most units will accept, a minimally negative margin?
Well, I think the problem that pathologists have is that it's much, much harder to assess margins in DCIS than it is in invasive breast cancer, and we've always known that. The guideline in the UK was a 2 millimetre margin for DCIS and a millimetre margin for breast cancer, but that's not really based on any evidence. So I think a lot of units just accept a millimetre margin. Obviously Van Noy's, they very much think that the bigger the margin,
kind of aim for a centimetre kind of thing.
But then again, if you do that, and I think other studies have tried to validate what he's done, and actually not got the same results as him. So, margins is a very kind of hot topic at the minute, especially as the Americans have just issued their guidelines saying that they will just accept no tumour at the inked margin, and there's no benefit of getting bigger margins. So, I think we're probably moving down the route of a millimetre margin.
And the only other thing I wanted to raise at the end, which of course wasn't assessed in this study at all, was other ways of modifying risk. So we focus on radiotherapy plus minus tamoxifen. Not many people use chemo prevention on top of radiotherapy. But if you got someone who had a high risk, either on this or any other predictive scoring system that you use, and they had a family history, what do you think about using chemo prevention instead of radiotherapy?
I don't know instead of radiotherapy, but I think in younger women, it's been shown that tamoxifen, there is definitely a benefit of tamoxifen in younger women. I think the difficulty we have with tamoxifen is, and there were numerous studies today that kind of demonstrated this, up to 40-50% of people don't take the tamoxifen. And if you've had DCIS as opposed to invasive cancer, to get people to comply, I think is difficult. So I think in the UK, we probably underuse tamoxifen in DCIS in younger women. But I think the difficulty we have is with the compliance issue.
Most people do finish their course of radiotherapy, don't they?
Yeah, whereas I think, people tell you they're taking the tamoxifen when actually they're probably not.